Hello, my name is Jacob Stevens, and I'll be presenting our study entitled Urodynamic Studies Before Anterior Compartment Prolapse Repair Procedure May Not Be Necessary. We have no disclosures. So a little bit of background. There's been an ongoing debate of concomitant stress urinary incontinence procedure at the time of pelvic organ prolapse repair. In 2012, the OPUS trial looked at patients in this category that underwent a repair for stress urinary incontinence and found that the number needed to treat to prevent one case of SUI was 6.3. The general standard of care used to unmask SUI in prolapse patients is reduction of prolapse on exam with a cough, pessary placement to see if the patient leaks, as well as urodynamic studies with packing to reduce the prolapse. The aim of our study was to evaluate preoperative UDS findings in women with symptomatic anterior compartment prolapse compared to postoperative continence status to determine its utility in surgical planning. We performed an IRB-approved retrospective review of all pelvic organ prolapse patients with UDS prior to repair of their prolapse for anterior compartment prolapse stage 2 or greater. Our exclusion criteria included those with less than 6 months of follow-up, those with concomitant SUI procedure at the time of a POP repair, which in our case was only one patient. And lastly, urodynamic studies that did not have both packing and non-packing sequences. Our data looked at demographics, prior bladder neck suspension, type of repair, UDI-6 questionnaire results, urodynamic parameters, follow-up self-reported SUI, and SUI or pelvic organ prolapse reoperations. Our urodynamics were done according to the UITN protocol, with packing performed using a lubricated gauze pack about 10 centimeters wide. SUI was assessed on UDS with cough or Valsalva. There were no primary SUI procedures performed regardless of the urodynamic findings, as the findings were only used for counseling for patients. Our primary outcome was the need for secondary SUI operation. Our secondary outcomes included post-prolapse repair self-reported SUI, as well as the UDI-6 questionnaire responses. Overall, 93 patients were included in our study as per the study criteria, and this table looks at the baseline demographics of those patients. We separated them based off of prior bladder neck suspension surgery, with 74 not having prior VNS surgery, and 19 of them having prior VNS. Overall follow-up in all patients is 2.6 years. There were no differences noted in demographics between patients with or without prior VNS. We did notice a difference in the type of repair based on prior VNS, with more patients undergoing anterior vaginal wall suspension if they did not have a prior VNS, and more patients undergoing mesh sacrocolpoplexy if they did have a prior VNS. This next table shows the overall SUI results, with no differences seen between those with or without prior VNS. We looked at patients with and without packing and noted that 27% of patients had SUI on the non-packing urodynamic study prior to their repair. On the packing study, we noticed that only 23% of those patients had SUI, questioning the ability for the packing to unmask SUI. UDI-6 post-repair questionnaire responses were positive for SUI in 18% of the patients. Self-reported SUI was only seen in 9% of the patients, with only 4 of those patients, or 50% of them, having SUI seen on their UDS prior to the repair. Secondary SUI operations were only needed in 2 patients, or 2% overall, with only 1 of these patients having SUI on their preoperative urodynamic studies. This figure shows the post-repair SUI outcomes based on pre-repair SUI UDS findings. The dark blue bar represents patients that did have SUI on preoperative UDS, and the light blue bar shows patients that did not have SUI on preoperative UDS. It's important to note that only 8% of patients with self-reported SUI showed SUI on their non-packing urodynamic studies, and only 14% of patients with self-reported SUI showed SUI on the packing urodynamic studies. This suggests that urodynamics did a poor job of predicting the patients that would actually develop postoperative stress urinary incontinence after their repair. Some strengths of our study include consistent teams that were used for patient evaluation, grading of the prolapse on radiographic studies, urodynamic performance and interpretation, as well as consistent teams performing the surgical techniques. We also separated patients based on their prior BNS and showed that there were similar results in the two groups. In addition, no patients included in our study received a stress urinary incontinence operation at the time of their pelvic organ prolapse repair. Some limitations include a relatively short median follow-up time of only 2.6 years, leaving room for patients that might have developed SUI after the follow-up period. We also had a limited diversity in patient population and a limited sample size that can reduce the application of our data to the general population. We also noticed that some women did have prior BNS or other POP procedures, and those were still included in our study. Our conclusions were that self-reported rates of post-repair SUI and need for subsequent SUI operation in women undergoing ACP repair were low and poorly predicted by Urodynamics. This led us to believe that Urodynamics may not be necessary prior to anterior compartment prolapse repair for surgical planning and patient counseling. Thank you.